Hello and welcome to How Would You Rate Your Pain? We will be exploring life, loss, love, and the power of resilience. I am Dr. Tiffany Bartell. Thank you for listening, and I can't wait to go on this journey with you. Hello and welcome to another episode of How Would You Rate Your Pain? I'm Dr. Tiffany Bartell, the host, and I am here with one of our family's dear friends, Dr. James Hart. Welcome to the podcast, Dr. Hart.
Well, thank you. I'm glad to be here.
So I'll tell listeners a little bit about how we know each other. You and my husband, Darren, have worked together. I think you were kind of his boss.
Collaborator.
And very quickly became friends. And then I feel like we've just absorbed you. You're kind of an extra uncle in our family. Oh, yeah.
I love your family.
Well, we all love you. The children get excited when Dr. Hart's coming over. And you let me try new recipes out on you. You're a very kind eater.
Yes. I like to eat.
So I wanted to have you come on today. You are currently the Chief Medical Officer at Erlanger Behavioral Health here in Chattanooga, and you're in the field of psychiatry.
Yes.
Over roasted chicken and other various meals, you've shared some of your story of what brought you into the field of mental health.
Right.
And I just thought the listeners would love to hear that story from you.
Sure.
Yeah. So tell me a little bit, as you were growing up, did you know what you wanted to do when you got into the workforce?
Well, I thought I did. I just knew that I was pretty good at math in high school. And so, and my uncle was a chemical engineer with DuPont here in town. Yeah. And
so are you a Chattanooga native?
From about the 5th grade on.
Okay.
Yep. And so I wasn't really sure what to do, but I knew that I did very well in math. I did well in math on my exams and, the SAT and so forth. And so I decided I was going to pursue engineering.
That makes sense.
Yeah.
Yeah.
So I ended up getting a scholarship to go to Texas A&M University in College Station. So I started off in engineering there, graduated in civil engineering in 1988.
Okay. Did you enjoy learning about engineering and your course of study?
Well, I was involved in a lot of student activities. So
you had a fun time.
Everything from Corps of Cadets to Kappa Sigma fraternity to the student union. I was one of the student affairs vice president or something along those lines.
Wow.
To just multiple organizations. I was a senator for the College of Engineering at one point in time.
Wow.
And so it's almost like I did so many activities in a way I felt like at times that's what I was majoring in. And then but I'd continue forward with my engineering classes and just kept going. So
you did school on the side?
Kind of, yeah.
You did college? College was your job and school was your side hustle?
Yes. And so, but then as I became closer to the end, I was like, the classes just kept getting smaller and smaller and smaller. And then I was kind of looking around and I'm like, well, what kind of, started looking for jobs and everything. And so I'm not really a cubicle kind of person. So basically, I immediately, in a way, pivoted.
Okay.
I took some prerequisite courses. I started working for a company in Fort Worth after graduation and began taking some classes at night for business classes because I was like, I've got to pivot away from just doing the pure engineering, maybe project management, something like that. So I started working on my MBA. Mm-hmm. And so I ended up going down to Baylor University and got my MBA from there. And that's when the adventure started. I did work for a few months at a consulting firm in Washington, D.C., and then the opportunity came along to work for Electronic Data Systems, which was huge at the time. And then I was on the General Motors account.
Oh,
and so at the very end of it, that's when I became, through them, I was EDS. I had gone to many places. I was in Thailand, Bangkok, Thailand. I was in the New York City area, right across the Hudson River. I was in Michigan, and so I was in a lot of different places.
Lots of adventures. How long were you in Thailand?
I was there for about a year. So we would go in these 3-month increments.
Okay.
And so I just kept staying on and on and on until I'd been there about a year.
Did you enjoy living overseas?
I loved it. It was probably, going from the Rossville, Ringgold, Georgia area.
A little bit different, right?
I never experienced. I remember when they told me if I'd be willing to go to Bangkok. For some reason, I thought that was a country at the time. So I actually had to look it up. And I'm like, that's a huge old city in Thailand. So, but I guess I just wasn't culturally aware at the time.
Had you been to Asia before?
Never.
Okay.
Never. I went because of the job.
Yeah.
And so,
stayed.
Yeah. So they'd have me basically... we worked quite a bit. The days were long there, and so, but normally we'd have at least one full weekend off a month, and I would,
you were working really hard.
Oh yeah, very, very hard, and so basically we'd get one free weekend a month. Now you would get like one day off at least per week. But the one full weekend would be at least once a month that I would go on these outings. So we lived in an apartment complex that they called it a service hotel. Okay. Our service apartment was basically, to me, it was like a hotel. But people stayed there for weeks and longer, not just 1 or 2 nights.
Okay.
And so that apartment complex had these formal things, and I would go on the weekend outings whenever it lined up. So it was great. I got to see all kinds of beautiful things there. I enjoyed being there. I enjoyed getting to experience the food.
Did you like to eat?
Oh, yes, but it took me a while to get used to.
Oh, really?
Because it was so spicy. When I first got there, all I would eat was the fruit because everything else was so hot that I couldn't really eat it because I just wasn't acclimated. But slowly over time, I did, and I loved to eat with the Thai locals, because we worked in an environment with Thai locals, and so. So it was very fun.
Did you learn to speak the language there?
I did, just a little bit. Like I felt, it's like I'm trying to learn 6 new words per day. And
that's remarkable.
Yeah. And so, but basically what it came down to is I really learned 1 word English-wise, but that equated to 6 words based upon what tone you would either go like, with the word ma, it was like straight ma, or it could be a low-pitched ma, high-pitched ma, or you would have these scoops from ma or ma. So that came out to about...
Oh, that's very efficient of you.
Yeah, so I would learn 1 word a day and equate it to the 6 words they had, and then I wasn't very good at the tonal stuff, so I just would use my 1 word. And
you're like, figured.
I couldn't really get the tone. I'm doing good just to get the words. And so I guess that comes with more, if you start staying there longer. A second year. Yeah, if you stay there a second year, maybe you can get the tones down. But I got quite, by the end, I enjoyed being able to, I knew enough to be like, to say where I was going or where's the bathroom, then understand where they'd tell me where the bathroom was.
That's the key.
Or, all of the basics that just as time went by, I got all of those down. So it made life there, in terms of when you go out into the community, it was more fun.
Easier. Yeah. So. And all of your adventures can be more easy that way too.
Yeah.
So how do you feel like coming from this area and being here so long, and then traveling to so many, Texas is very different than Tennessee, which is very different than New York City or DC or Michigan or Thailand. How do you feel like that affected you or shaped you as a person?
Oh, well, I've made it full circle.
Here you are back.
I'm back again. So I just remember in the, I wanted to go somewhere different for college. So there was Georgia Tech, Texas A&M. Those were the top two I was looking at. And so, but Georgia Tech didn't give me any money, so I went to Texas A&M.
They helped you with that decision.
So basically, it was one of those things where, for some odd reason, I was ready to leave Chattanooga. When I was in high school, it's like that's what I wanted to do. To graduate, go to a good college, make it a somewhat of a new experience, things like that. And so, but I would always continuously be coming back to Chattanooga every year, multiple times, 2-3 times a year, twice a year.
Oh, wow.
And so forth. So, because my whole family was here. So, and then basically, as time went by, there was a time in my life where I felt as though I was needed back home, and that's why I moved back home. Yeah.
Well, and I would think that, especially in the work that you do now, it must be really helpful to have spent time other places and been with people from all different cultures and backgrounds and
very much so.
Have that context.
In psychiatry, you really can't be judgmental. You have to be. I think just the exposure. I had never met a Muslim person before leaving here. I had never met a Jewish person before. It's different nowadays.
Sure.
And so I wasn't really culturally versed. I don't know how to describe it, but now with exposure, it's like I just love meeting people from different backgrounds and so forth and so forth. I enjoyed living there. I enjoyed going to Bangkok, to Beijing, and then growing up, we did have a stint where we lived in Madrid.
Oh, wow.
So I just loved all those kind of things. But so I think it helped. That has helped me become a better person today.
Yeah, I love that.
Yeah.
So engineering, General Motors. How did you end up in psychiatry?
Well, that's interesting because I actually ended up getting dysentery while I was in Thailand. Now, you have to remember, we were on one of our excursions. They tell you please do not eat anything off the side of the road. I did not listen. It looked so good. So I ended up eating one of the vendors that I probably shouldn't have had and ended up getting dysentery. So at the point, I thought I was going to die there. So I had no medical experience. Looking back, I don't think I was going to die there. So.
It felt like it.
It felt like it, though.
Yeah.
And so that kind of just got things, in a way, just kind of got things, ideas flowing. I never really had... I really hadn't had a chance to reflect back on the choices I've made and if there was anything I would do differently. And I just kept coming back to, I'm in this environment and there's all these people just helping me. And it's like, I just remember at the end of the day, these people are going home and they're like, in my mind, just having helped somebody and, it's just a different level of, when you're working with manufacturing type environments and so forth. And so, I thought that was very admirable.
Yeah.
And so I'm like, well, if I was to do something differently, what would I like to do? And I just kept coming back to medicine. And,
to help people.
Yeah, to help people. But it was very, but at the same time, I started looking at the numbers just to even get into medical school. And so, honestly, I didn't think I was smart enough to get in. Well, when you have all these thousands of people applying, it's like, I just didn't really know. You know what I'm saying?
Yeah.
It's like you can take nothing for granted in my mind. And so it's just like, okay, I'm going to do this. I'm going to try this. And if it doesn't happen, I can be 80 years old and have no regrets and know that I tried and keep going.
That's a
just
great
keep doing what I'm doing.
Yeah.
But I would have never been able to been like, I don't think I would have ever felt comfortable not ever having tried, because I didn't want to tell myself no. I wanted the schools to tell me no. Like, you can't come here.
Yeah.
Does that make sense?
I like that.
Yeah.
Yeah.
So I ended up getting accepted on the first time.
Turns out you're smart enough, which I could have
I'm
told
like,
you.
well, how many times should I give this a try? 2 or 3? So basically, and I just, I think it was just very kind of cool that it happened on my grandmother's birthday. She was deceased at this point in time. I'm like,
that's
wow,
lovely.
this is my grandma just looking down, being
It's
like.
a good sign.
Yeah, it was a good sign.
Yeah.
So I'm glad I made the choice.
So how was medical school for you after having done engineering school and then your MBA?
Well, it was completely different for me because like I had never had, most of the people in the class, there's me and a math major, but most of the people in the class were prior EMTs, prior techs, prior PhDs, prior PharmDs. Most everybody had exposure. My exposure was being, I rolled people around in the hospital for my volunteer work. So,
that's exposure. Not maybe as helpful, but yeah.
So it was just a completely different experience. Like I'd never had anatomy before. I'd never really had biochemistry before. I never really had physiology before. I never really have had hematology before. I've never really had some of these things that most people have had exposure to in their undergraduate or some graduate work and so forth. So I had the very bare minimum requirements, which now I've heard they've been expanded from when I went through the process. So it was very difficult.
Oh, I bet that was such a big, like you mentioned pivot before, but what a big pivot to have to kind of start and absorb all that foundational information.
Right. It was. I will not lie. I will not try to sugarcoat it. It was very difficult.
Yeah. So as you were going through medical school, did you know that you wanted to go into psychiatry?
Actually, I was planning on going into family practice. So my brother-in-law at the time was a family practitioner. I thought, we were talking about, I'd go and just follow that stream of into that practice and so forth. Yeah. But then as I went along, I did a psychiatry rotation. And so, oh my God, I loved it. Absolutely loved it. Switched my electives over, so forth, so forth. And I'm just like, oh my God, well, what do I do? So I felt by this point, maybe the train had gone too far and there's no turning back or whatever. So, I decided to go ahead and go with psychiatry anyway.
So what did you love about it? Like what kind of resonated with you?
I just really enjoyed working with the patient population. And, I'm putting things in higher categories now. Like, kind of going through things in the eyes of a third year. I thought the patients were great to work with. I really enjoyed working with them. I thought the pathology was just fascinating, how the human mind can do things. Yeah. And then, I thought they had the coolest drugs. I don't know how to say it. I was like, man, these are cool drugs.
I don't want to prescribe amoxicillin for the rest of my life.
This is much more interesting than doxycycline. So the combination is, and then it was one of those things, not just that, but I enjoyed learning about that. I like, because I know, they talk about how there's lifelong learning and so forth and so forth. To me, this is enjoyable to continue lifelong learning on. Yeah. Does that make sense? It's not a chore for me. I actually enjoy it.
It makes sense to me. I'm a total nerd.
Yeah,
and when it comes to mental health, I have a budget for my CEUs that I try to really strictly stick to. Yeah. Otherwise, it gets really out of hand.
Yeah. So actually, that's one of the things I'm doing right now, CME on to get my DEA license renewed. So apparently there's this new course that's 8 hours that you have to take.
Yeah.
So the one I chose is something I'm kind of doing right now.
That's so fun.
And it's interesting because the last 4 or 5 modules, one is, of course, in psychiatry, there's a specialization in substance and addiction and so forth. And so we got one module, substance use disorder in general. Then we got one module on alcohol, one module on stimulants, one module on opioids, just all so they break it down even further. So I'm like, oh my gosh, this is so applicable to what I do.
It's so interesting. Yeah, absolutely. Well, and I think that's kind of the fun part of like when you find your place in the world and you're just, it's enjoyable to do the work and interesting every day.
Yeah.
And
So that, because there's times where I work very long hours, and that to me, it does make a difference when I don't think you could do that if you didn't enjoy it. You'd be miserable.
Yeah. And the patients would feel that.
Yeah, of course. So I just feel, very honored, just blessed that I've been able to find an opportunity or a field of medicine that I just love so much. And so I feel very fortunate.
Yeah. Well, I think your patients do too.
Oh, I hope so.
Yeah. So, as you think about your work in the field of psychiatry and mental health, what's the hardest part about being a psychiatrist?
Oh, honestly, it has nothing to do with the medications, has nothing to do with anything along those lines. It has to do more with just some of the case management type scenarios, just, discharging somebody to a shelter, knowing that they'll be back almost within a month. It's sort of like things that in a way are out of my control.
So like when you can't see that they're going to a place where they're going to continue to thrive and get better.
Right.
Yeah.
I love it when we have places where people can go to, like if they're going to like a group home or a rehab or, something like that. But just sometimes just discharging a person back to the shelter, I'm kind of like, well, I don't know how they're going to do in the shelter, but they're capable of, I can't make decisions for them in terms of like where they go. They have to be willing to go to where they're going for the most part. And so it's just more of the social situation sometimes can be difficult.
Well, and I think that's important to for our listeners to hear, because that's where the rest of us come in. Is we as a society and a community, it's our job to make sure that our most vulnerable populations are cared for and have the support and resources they need. And there's good work being done, but there's always more that's needed.
Yeah, absolutely. And let me tell you, those case managers work their butt off. Oh my gosh.
I couldn't do it. They're rock stars.
Yes, absolutely. And so, so I guess in general, that's one of the most difficult things to see. But if they come back, I'm like, what? Nice to see you again. Come on in.
Take care of them again.
We'll take care of you.
You'll help them again.
Yeah, of course.
So what are some of as you've been in the field of, mental health, what are some things that you've seen, what do you think are some of our most pressing issues when it comes to mental health, today?
Maybe it's because of where I'm located now. But to be quite honest, I have never seen meth use so prevalent, as it is now.
Yeah.
And that's a huge issue. So I guess it relates back to substance related for people in the community that are having difficulty with that.
Yeah. So it's back to resources.
Yes.
And I think that, there's so many of us, when we think about mental health, we're thinking about anxiety, depression, suicidal ideation, even mood disorders like bipolar. But I think that so many times, unless the conversation is specifically on substance use, we're really not realizing how many people are affected.
Oh, I'd say at least half the people I see coming into the hospital have some type of substance use on there. A lot of comorbidity.
Yeah. Well, those dual diagnoses are kind of a feedback loop, right? Where
Yes.
they kind of feed into,
Yes.
each other.
Yes. So, but one thing I have learned is as much as I can, unless the person's ready, I have many times fallen into the trap of working harder at somebody's rehab than they are. So at times I've just learned to have to step back and respect their, like I can't make them do anything. They have to want to get help. So.
Well, and I think like that sense of urgency that we have, it almost like prolongs the process
Yes.
of, there's no space for them
Right.
to have the full consequences, and to be ready themselves. And so we want to drag people into treatment for lots of things.
Yeah.
So what do you see as like, what can people do to help? You have, you mentioned the, meth issue, especially here in the South. What's the answer?
Well, I think a lot of it has to do about availability. There doesn't seem to be, there's availability, but it seems to be very limited. And so,
For treatment?
for treatment. Yeah. Because not everybody has an income. So then they go on a grant, our insurance, they go on a grant bed status. And those can take weeks
Yeah.
to get a bed. And so just the limited availability rehab for individuals that don't have insurance.
Yeah.
And then I consider that to be their biggest peak relapse time is the time they leave the hospital, because we can't just house somebody for weeks on end waiting for a
Right.
bed to open.
Right.
So it's that period, they're extremely vulnerable between the time they're discharged until the time they get into a facility for rehab.
Okay.
And many of them relapse in that window. So you lose them. And then they'll be back one day.
Yeah. And we hope,
Yeah.
because you don't always get promised another try at it
Right.
when it comes to substance use.
Exactly.
And I think, it's been really alarming that, cases with fentanyl use and the fatalities of young people.
Yes.
And it's really scary. I love that. So what advice do you have as a doctor for family members of people who might be struggling with, any kind of mental illness? Like if you see someone you love struggling, what's the best advice you have for them?
I think is to, well, first try to be like, ask, is there anything reach out to them so they know that their family is trying to make sure that their loved one is okay.
Yeah. So care and concern.
Care and concern. And then I recommend, 80 primary care providers they provide 80% of mental health services. So they are actually the front line to all of these kind of issues. So if it's something in regard to, anxiety, depression, so forth and so forth, they'll typically manage that. But then if it continues to become, if they see that this is no longer in their lane, the other 20%
gets referred.
It gets referred and sent into the mental health world. And then I kind of think that that's where I kick in there is with that portion.
Yeah.
But say the individual has the mental illness, there's a wonderful organization called NAMI.
Oh, yeah.
Yes.
Yeah.
I always
their work.
recommend them. Always recommend them to the families. They are such a crucial resource, because then it's family members relying, they are able to reach out and talk to other people that have been through or are going through what they are going through now and the difficulty of that.
Yeah.
And so that's
and they're so knowledgeable, so many resources.
Oh, yeah. But they're my go-to place.
I love that. And we actually have a really strong chapter here in this area run by really wonderful people.
Oh, yes.
Yeah.
And so, but that's where I refer to them.
I think that's so good. So, just, it sounds like being empathetic and showing your love, but also getting, informed resources for yourself and for them.
Right.
because I think when we love people, we just want to surround them and like love them out of it.
Right.
And oftentimes when it comes to mental health, it's just a bit more complicated than a matter of knowing people care. Things get tough.
But I always have to remember, too, there was a patient I had, she made such a profound statement, and I didn't know why it was so profound, but at the time, I was just like, oh my God, she's right. Because I was trying to explain to her, family was trying to help her and get involved, and she was refusing everything, and she had been doing this for years. This was not new.
Okay.
And I said, well, I tried to explain to her, I said, well, most families, the reason that they're acting this way is typically out of love for your concern and so forth. And she goes, she says something along the lines of, well, you have to remember there's some families that don't do that.
Mm-hmm.
That I am not in a loving household.
Okay.
And I was like, what a concept. I don't know why I've never thought of that before, but I'm like, she's absolutely right.
Mm-hmm. Yeah.
The ones that are supposed to be centering around you are now the ones that are being like, not necessarily that worried.
Yeah, or like the
they burn
feedback
them
is
out
not,
in a way.
Constructive. And
yeah.
Well, I think that's where some organizations like NAMI can help to be, you can be connected and loving. Because I think if we try to do it ourselves, we go through these periods of time where we're really, codependent and then enabling and then tough loving. And then like we're trying to kind of figure it out ourselves.
Yeah.
And why not walk in those footsteps that other people have kind of mapped out that work? So if somebody's listening today and they are struggling with their mental health, but they're afraid of going to the doctor or a psychiatrist because they're afraid of taking medicine or becoming dependent on something, what would you say to them?
Oh, I'm a huge advocate of therapy. If you don't feel comfortable seeing a psychiatrist, please go see a therapist or a psychologist or somebody that you can discuss these issues with. I went to the program I went to for residency was very aligned with a PhD program for the psychology students.
Oh, how wonderful.
And so they actually, it was such a strong alliance that I remember when I first started, like basically at the time, the first year of residency, like therapy was required once a month for all the first year residents. And then after that,
In the program. I love that.
Because there was such a strong alliance between the PhD program and our residency. And so after that, I think for year 2, 3, 4, it was optional. Okay. I just continued. I was like, oh my gosh, this is great. Then when we're starting to close it down, I'm like, no, wait, I have so many things to talk about still. But the thing it taught me was how valuable therapy can be. And I haven't had a need to get, therapy since then, but I would like to think, actually, I know if I ever felt like I needed therapy, I'd have no problem. I'd be like knocking on their door.
Yeah.
Hey, I need some help over here. Can you help me try to work through this? Or something like that. So I always recommend therapy.
Well, I appreciate that as a therapist.
Yes.
There are some people that do need medication, though, to save their lives even sometimes. Yes. What would you say to people who, are afraid to take medicine, or maybe, they've grown up in families where, we don't take medicine for things, or they have a fear that it'll change their personality, or, a lot of these are a lot of the things that I hear when clients are like, I got prescribed this, or I've been diagnosed this, I'm not well, but I'm scared.
Well, usually the approach I take is, in outpatient, I always prefer if somebody can be in therapy and with psychiatry at the same time, because I've found that works the best. And so in that case, it's a lot of reassurance, starting low with any medication. Actually, what I normally would do is I'd give them 3 options.
Okay.
I've learned that if I don't engage the patient to a point of where they need to be actively engaged in their treatment plan, because if they're not actively engaged, it's not very successful.
Yeah.
So I would always say, out of these medications, this is probably the advantages of this med, and then next, the advantages of this med, and then third, like advantages of this med, because there are different side effect profiles that may impact one person, but the other person could care less about.
Right.
And then they're
give them power to make the choice for themselves.
And then then the typical question is, well, which one would you take?
Yeah.
And I'm like, well, I'll tell them I would take this one, but that doesn't mean that that's the one that's right for you, because, like say one of the common side effects associated with like SSRIs and so forth, and particularly in the concern with the younger population, is sexual dysfunction.
Sure.
So things like that, like, so we'll have a tendency to lean more towards like Wellbutrin and so forth and so forth. And, so things along, like there's a specific side effect, like, I prefer this one because it doesn't have weight gain.
Yeah.
So basically I give them, to try to keep it, somewhat contained, 3 options.
Yeah.
Which option would you like to go with? So I let them pick.
I like that.
We'll focus on side effect profile and so forth. And then we always look in terms of past medication failures.
Sure.
Like try to find an option that they, will agree with.
Yeah.
So.
Yeah. And feel better.
Yeah.
I think, one thing I talk to my clients a lot about is, I think at any stage of our lives, no matter whether it's medical side, our social side, our psychological side, I think as humans, we have to just be committed to ourselves that whatever we need in life, we give ourselves permission to take advantage of it.
Right.
So it's, I remember in my 30s, we have genetic predisposition to high blood pressure. And I exercise every day and I eat really well. But I just ended up having blood pressure issues. And I didn't want to take my blood pressure medicine because to me, it was like a signal that I wasn't like living healthy.
Aww.
And I really kind of had to like wrestle with that. And at the same time, I'm being a therapist and telling my clients, like, we have to give ourselves permission that if you're so sad you can't get out of bed, then we need to help you. And you should have access to any help you need. And then you hear yourself and you're like, okay, I'll take my blood pressure pill. It'll be fine. But I think it's hard sometimes, because we have these expectations of ourselves that everybody else can get help and everybody else, does that. But I don't need that.
Right.
And I'm not that bad.
Right.
And I'm not suffering that much.
Yeah. That's why they call it the silent killer.
Oh my goodness, yes. But I'm taking my blood pressure medicine. My blood pressure is a picture of health right now.
Oh no, I just remember I went to the dentist one time and the diastolic was like 100 or something. That's all I needed.
You were like...
Got into PCP, so I'm on one too.
Yeah, well, and that's okay. Like, we do need to take advantage of like social supports and healthy relationship with ourselves, therapy, all those things. But if we need something else, why would we treat it any differently than diabetes or any other condition where our body needs help?
I use that same example myself all the time.
Yeah.
Like this is an illness, and just like if you had diabetes, we treat that. This is a mental illness, we treat that. It's no different. They're both an illness. And so I try to like help them understand that this is just as important as if you had diabetes or if you had hypertension or,
it's just another part of your body.
It's just another part.
It's not different because it's your brain. And, I think that, our thoughts and feelings are chemical and electrical, and your thoughts and feelings are the pain of the brain. So when you have thoughts or feelings that don't feel good and too long or don't make sense, then it's your brain telling you that something is happening. And I think there's a lot of lifestyle medicine that affects your, brain chemistry that's really helpful. But there's sometimes when we're just so sick and we need help, and that's okay. Yeah. So where do you see the field of psychiatry and mental health going? What would be your hope if you could, be the chief medical officer for the country and do everything you wanted to do?
Excuse me.
Where would we be in 20 years?
I think the future is headed more towards, like right now, they're doing like PET scans. They can identify different areas of your brain that will light up if, say, you're associated with schizophrenia or with depression or so forth and so forth. And so eventually, I think one day it's going to be a combination of helping to use that to help us diagnose more accurately
than symptoms.
Because there are so many things that can be, it can take, as the longer you get to know somebody, the more formalized their diagnosis becomes.
Right.
Because it can be very difficult at times. Is it a primary psychotic disorder, or is this a mood disorder with psychotic features? It can be a toss-up sometimes.
Yeah.
And so, but after the years, you kind of get a generalized feeling which one it is.
Yeah.
But so I think that would help. Looks like I just saw, am I allowed to say I just saw an episode of 60 Minutes?
Yes, of course you are. Okay. Yes.
I don't remember the physician's name, but he's kind of leaning into a field now. I think he's actually a neurosurgeon, and he is like pinpointing this specific area in somebody's brain for, like, say, substance use, and helping, like, I guess they bombard that one little area of the brain, and that helps to reduce the cravings.
Interesting.
And his test subjects are, people who have failed everything that
treatment
was
resistant.
Yes. So I'm like, wow, this guy's got
something new to offer.
Yeah.
Yeah.
It won't be soon.
Sure.
But that possibly could be in the future if his research keeps panning out.
Yeah, there's
things like that.
So many new innovations that can help some of the population that maybe like a first line SSRI or something isn't helping, and they're going through all these iterations of medication, hospitalization, and relapse.
So for now, we have for refractory, there's an ECT unit at Erlanger. It's electroconvulsive therapy. And so that's, in a way, there are no absolute contraindications to ECT. But that's kind of like right now we have ECT with refractory depression. There's Spravato, where they do the nasal spray of ketamine. We do have, there's the magnet, I believe it's TRM, maybe. It's a form of using magnetic fields to help alleviate depression.
Interesting.
And so, so there are things that we're using now, and it continues to get a little bit broader. But ultimately, I think eventually it'll be a combination of ECT or the PET scans, meds, working together.
I love that. That's kind of exciting to think that people can get, help faster.
How could I forget? Even with gene site testing.
Yes.
Nowadays,
so interesting.
I use that all the time. Not in this most recent outpatient experience, but when I was where I was at before, we would use that to help guide somebody. I used it all the time to help guide an individual toward, like, okay, these medications are, it's all based upon metabolism and so forth. And so these medications get, it's like a traffic light. They came back green, yellow, and red.
Yeah.
But so normally I would always just trend away from red. There's no even point in even really discussing those. So most of the time I would go with anything that was in the green category or anything that was in the yellow category, but at times I'd look what was in the yellow and look at what it was broken down to in terms of the metabolism. And I'm like, oh, okay, well, I could go with a lower dose, and this would have a tendency to hang out in their system a little bit longer because they're not metabolizing as rapidly as,
Oh, interesting.
So there's times when I would use that yellow column to my advantage in terms of picking a med.
So for listeners, so there's some genetic testing that you can do that helps indicate how you metabolize different medications.
As well, yeah.
And, because I think some people who have significant mental illness, they'll find, they'll try a medication, 6 to 8 weeks. Then maybe they'll dose it different and then try a different one. And it could be a really long, exhausting, discouraging process before you feel better. And so this gives you an opportunity to kind of fine tune and have early interventions be as impactful as possible.
Yeah, because when I started residency, it was more like, okay, well, we have a group of meds that's supposed to help.
Yeah.
But in a way, it was kind of like throwing a dart at a dartboard. You just now, pick one, let's go with it, let's see if it helps. Nowadays, I think it's much more, when available, it's much more specific in terms of selection of meds.
Yeah. And it can get even more so because I think, especially when you're talking about using PET scans for a diagnosis, like how exciting that you won't have to go through a misdiagnosis and, think it's depression, it's actually bipolar, get pushed into a manic, so difficult sometimes. That's exciting.
Yeah. So that's the future.
That's the future. Well, I'm glad that you are a provider in the present.
Well, thank you.
Thank you so much for coming on and talking about your journey and what you do.
Well, this has been a pleasure, really. I didn't know what to expect, and so I just figured, well, I'll just answer her questions.
And you did beautifully. You did beautifully. Now, but I'm really curious. Sometime I'll have to have you tell me what that one word in Thai means in the 6 different iterations, because I'm really curious when you were using it like statically.
I think
what you were saying.
It's kind of funny.
Okay.
So I remember Ma meant like cow, and was one of them. I mean, there was like a whole.
Yeah.
I don't really remember much of them now.
Okay.
But because it was so long ago. But I remember cow was one of them with Ma, and I think milk might have been one of them.
So sometimes you were asking for a cow, and sometimes you were asking for milk. Sometimes you were eating milk and drinking a cow. Yeah, that's amazing.
So you just had to hope they were able to interpret my one word for 6 meetings.
I'm sure they were getting to know you as much as you were getting to know them.
Yes, very much.
That's wonderful. Well, thank you again for being here.
Oh,
and
thank you.
Thank you to our listeners for joining us today. Just want to encourage you to be gentle with yourself and make sure you're finding spaces where your story can be told. We'll see you next time. Thanks for listening to How Would You Rate Your Pain? Please subscribe on your favorite listening platform so you never miss an episode. And if this show made you think of someone, please share it with them to help us grow. I'm your host, Dr. Tiffany Bartell. You can find me on Instagram at the_happy_therapist_. This show is not intended as medical advice and should not take the place of therapy or other mental health services. Please consult with your doctor or mental health provider about your own health. You deserve all the support. How Would You Rate Your Pain is co-produced by Wavelength Studios and Chattanooga Podcast Studios and is part of the Podnuga Network. Graphic design provided by Josh Wilhelm at JW Creates and music by Michael Crosa. I'm Dr. Tiffany Bartell. Thanks again for listening. We'll see you next time right here on How Would You Rate Your Pain?